foundations for what is in essence the relationship between the medical and legal system, because understandably the legal system, of course, turn to the medical profession for their expert opinion. And for anyone interested in the subject, I couldn't recommend any higher this particular journal, which is a unique journal dealing with an individual seminal case in the mid-90s in America, in which it stressed brain injury and legal responsibility, and what they did after the case, in which an individual was charged with murder for strangling his wife during a domestic tiff and then tossing her out the window of the high-rise down onto a busy street, and then casually walking out afterwards. He was found to have an arachnoid cyst in his frontal lobes, and the whole issue was whether he was medically responsible for his actions. And what this unique journal does is it takes the experts from each side and criminologists, and they address the whole case in great detail. And it's a superb read if you're interested in the subject. And that's why I want to start with this and read, although it takes a little bit of time, won't take up too much of your time, but it's important from the point of view of laying down the foundations of what's at stake here. The most difficult question in neuropsychiatry pertaining to the determination of causality, which is the key issue, is the lesion which is seen in the MR the cause of the observed symptom or behavior? Is the focal temporal slowing noted in the EEG indicative of a seizure disorder? Or could this mild head injury have caused such a marked behavioral change? These are sort of questions which clinicians struggle with every day and are frequently formed as hypotheses in order to treat patients. However, they become very difficult when they have to be answered in court, where our clinical hypotheses often do not impress the legal system. Certainly, all of the new imaging techniques and functional evaluations of the central nervous system are providing us with abnormalities, in inverted commas, for which we have as yet no clear brain behavior correlations or even a neuropathological referent. Consequently, we are frequently confronted with a pathological, in inverted commas, finding that may or may not be related to the pathology we are attempting to investigate. While we are used to tolerating such ambiguities in the medical system, the legal system is not. So that's the first comment. The author goes on to talk about mitigation. Three questions, he says, need to be addressed when discussing mitigation, which should be answered in the affirmative. One, if brain damage exists, does it produce a deficit in the individual's ability to conform his or her behavior to the demands of law? Secondly, is the resulting deficit a contributing cause of the defendant's actions? And finally, most importantly, can a persuasive argument be made that absent the defect, in other words, without the defect produced by the brain lesion, the criminal action would never have taken place? So these are questions that the courts want answered clearly. And a criminologist, and finally, I'll just, before we move on to the medical side of things, an expert criminologist called Stephen Morse, in his analysis, puts forward the following. An analysis of moral and legal responsibility must begin with a normative theory of and criteria for excusing conditions. Assessment of responsibility in individual cases requires patient, cautious attention to all of the evidence, logically and empirically relevant to the presence of genuine excusing conditions. Only if one understands the theory and criteria of excuse, however, can we fully appreciate what evidence is relevant and why. Causes of behavior are not excuses per se. Even confirmed causal physical pathology does not excuse human action unless it produces an independent excusing condition, such as a lack of capacity for rational conduct. So these are the sort of strict rigors that the courts demand in our evidence and thinking. Moving on to the medical side of things, what I want to do is just to talk about potential theorizing or understanding on an individual basis of what might underlie someone's mitigating circumstances. And we're here talking about frontal lobe brain injury, which is the most common cause of ending up in the courts. And because of the sheer amount of symptoms and signs turned out by the brain, we make crude attempts to sort of categorize them under these three categories. However, when we're trying to anchor them in the brain, we have to remind ourselves that gone are the days of Franz Gall's phrenology, and we have to think in terms of systems. And this goes back to a statement of Benton in 1981. But there are certain increasing evidence of different systems and what they do in the brain. The neuroscientists talk about eloquent cortex, which is essential for particular functions. And what Damasio is talking about later on, I'll show you, is that there's potentially an eloquent cortex for something which is very relevant to someone's behavior after a traumatic brain injury that might be accepted by the courts. So in terms of cortical functions, in the frontal lobes that we're interested in, there are cortical subcortical circuits which appear to operate independently and appear to produce separate syndromes in themselves. So, for example, the one that we're most interested in, the orbital frontal syndrome, is responsible for producing things like disinhibition and impaired judgment and insight, the sort of thing that the courts are going to be interested in. Whereas the dorsolateral syndromes, certainly the stimulus-bound behavior is going to be very relevant to the courts, whereas the medial frontal or anterior cingulate, as it's otherwise known, probably isn't going to be particularly relevant. But if you damage the orbital frontal in particular, you're likely to have some explanation for your behaviors. This is just spelling out the problems in relation to different areas. Again, the dorsolateral being more of a cognitive dysexecutive problem, the orbital frontal more to do with personality and behavior. Look at the bottom line, the decreased empathy, civil and socially appropriate behavior, which is likely to run you into trouble. And then the anterior cingulate or medial frontal, less likely to be relevant to the courts. In relation to what the courts are interested in, they're interested in a diagnosis. And the most frequent diagnosis of relevance here is organic personality disorder, as the Americans call it, comportment. And this, of course, can significantly affect areas of interest to the courts. And this is the fundamental damage: understanding other people's feelings, disregarding social rules, and not learning from previous experience. So in other words, there's no point in giving you a particular punishment in the course because you just go ahead and do it again. Phineas Gage, interestingly, although he was changed fundamentally as a person, as far as we know, never ended up offending. In other words, he never ended up in the courts, though his behavior was certainly unacceptable, and he was no longer recognizable as the previous very diligent, responsible individual. It was recognized, the similarities were recognized between sociopathic or now known as dissocial personality disorder or psychopaths, and what happened to individuals after a closed head injury with orbital frontal damage. And as a result of that, the initial study started to look at things like the Hare psychopathy checklist to see did these individuals with acquired brain injury or pseudo-psychopathy, as Benton coined it in the mid-70s, were they similarly disposed, and was there a similarity between the two groups? In other words, the born or evolved psychopaths and the acquired brain-injured dissocial personality. But the Iowa scale, the Hare psychopathy checklist didn't quite capture this group of individuals. So Iowa group went ahead and developed their own rating scales based on just sheer numbers of orbital frontal individuals who they could identify through neuroimaging. And they drew up a whole list of all the different symptoms that these individuals manifest as a group, a collective group, a cohort. And as you can see, there's quite a broad list of. And then when they applied them to a cohort in which they had clearly identified through neuroimaging orbital frontal damage, this is what they found. And what's interesting, and this leads on to the theory of what's happening at the orbital frontal level, Damasio's theory, was the dampening and poor modulation of emotional experiences, apart from decision-making problems and goal-directed behaviors. The insight, of course, you might already have predicted, but there was something about the emotions and the decision and their effect on the decision-making which caught Damasio's eye. These were individuals with very, very localized damage in a particular orbital frontal ventromedial surface. And they consistently had difficulties, as Damasio points out here, in rational decisions and social matters. And emotion crops up again. And he coined the somatic marker hypothesis. And the basis of that is that the orbital frontal area and the somatic sensory strip have direct connections which formed a somatic marker, and that there was something being damaged at an orbital frontal level, which was interfering with the people's individually to people's ability to emotionally respond to a particular decision. We always think of decisions as very rational, very logical, but in fact Damasio was saying that emotions are a critical part of decision making. And that's, he spells it out. And again, highlights the interaction with decision-making and emotions. So what they did was they developed a gambling task. And the idea was that there are 4 stacks of cards, and they're unevenly biased according to winnings and losings. So you win high at the beginning, but you eventually lose. Whereas if you win low at the beginning, you eventually win. And the normal population were able to adapt during the gambling task, and were able to shift the way they betted, the stack of cards they betted, even though they weren't logically able to rationalize why they were doing it. They invariably turned out winning in the long run. Whereas jointly, the orbital frontal brain injured individuals and the psychopaths were failing on these tasks, and they failed to switch from one pack to the other, or one stack of cards to the other throughout the task. And when they were wired up to, they themselves volunteered that they never developed any hunches as to what was going on. The normal population said they had a hunch that they should be shifting their attention, whereas the brain injured individuals and the psychopaths didn't. And when they wired them up with galvanic skin responders, galvanic skin measurers of sweat, they found that the brain injured individuals and the psychopaths didn't sweat in anticipation of the particular task, whereas normal people did. So at a subliminal level, the normal people were getting some sort of cue. They weren't aware they were sweating, but they were obviously getting some sort of emotional cue which was guiding their choice to the correct area, whereas the brain damaged individuals and the psychopaths weren't getting that. So the conclusion was, on this, going back to the somatic marker hypothesis, that the highest level of decision making is not at a rational, logical, sequential level, but it's actually at a gut feeling. So in other words, if you lose the ability to feel what the right answer is, if you're standing beside a bush in the middle of the night and it rustles, and you don't run away at a gut visceral level, but go to explore what's in the bush, then you've made the wrong choice. So what Damasio is saying is these individuals who would acquire brain injury and the psychopaths are actually labouring under a great disability, and they've lost that instinctual emotional cue to make the right decisions. When it comes to legal responsibility, of course, you first of all have to break the law, so you have to have carried out an illegal act, but you also have to have formed an illegal, you have to have a guilty mind, so a guilty act and a guilty mind, so you have to have intended to break the law. And this brings us to the fundamental issues of capacity. You can see three of those are heavily weighted cognitively, but it's the weighing of information which is fundamentally impaired. And you have to be able to appreciate the consequence of your actions and take into account the risks and benefits of making the choice, which individuals with orbital frontal damage are not doing. As you will remember, in terms of the Insanity Act, there used to be a division between on automatisms between a sane and an insane automatism. A sane automatism was where someone slipped a Mickey Finn into your drink and you carried out an act. And the reason for that was because the cause of that act was external to you and therefore unlikely to happen again unless you went to the same pub and they're used to slipping Mickey Finns in your drink. But if in fact you had an insuloma and your blood sugar drops, you would be insane because the cause of that particular disturbance in your mental function was internal and likely to happen again. The problem with folk with orbital frontal damage, as we saw earlier on in the syndromal levels of brain injury, is that they are by definition environmentally bound with what they call stimulus-bound behaviour. As of an individual who I was asked to see in Ashworth, who had been under 3-to-1 surveillance in his room for a year, and when they brought him out for me to have a chat with him, he sat across the table, leant over, took my pen, started writing, and wrote down the leg of the chair and across the room. And it didn't take much to see that as a stimulus-bound perseverative behaviour, and sure enough, his frontal lobes were almost non-existent. So if you're environmentally bound and stimulus-bound, then you're not acting under free will, as of course would be a mitigating circumstance if someone holds a gun to your head and forces you to break the law. And the types of decisions which the orbital frontal lobes are particularly important for are not the ones when they're sitting across from you in the laboratory setting and you're asking them formal questions in a structured setup. It's in the real world where the rules of behaviour are not explicit and the meaning of events are implied and the behaviours are uncertain. I was involved in an uncomfortable appeal to the Supreme Court at the time in Dublin, where the government appealed a lower court decision based on someone who had a brain injury and was due to receive a mandatory sentence for a 2 strikes and you're out clause, having sexually offended for the second time. And the judge in the first court said they accepted the mitigating circumstances of the brain damage and reduced the mandatory sentence. Unfortunately, it was the first case under the government's new law and they weren't too pleased. So the second court overturned it. And when I was asked what were the features that implied he had frontal brain injury, I said that, well, the barrister had on the previous occasion told the chap never to have sex with a woman again without her permission, and if necessary get it in writing, so you can guess what he did at the time of the offence, which the judge interpreted as extreme perversion. The fact that he not only did what he did, but he got her to sign an IOU or an affidavit or whatever. So these features are very important in terms of teasing out the particular behaviour at the time. The problem, which can be disarming, is that these individuals, when you interview them, particularly adults who have received the brain injury, not children or adolescents before 10 or 11, they can tell you exactly what they should and shouldn't have done. In other words, they retain the actual rules of social encounter, the social game, but they don't actually do it on the day when the stimulus is particularly overriding. And this can be very disarming in a court of law when the judge asks them what they have done, and they tell them, broken the law, and I've done this, and I know I shouldn't have done, and you name it. Unlike with children who have not had the adolescent opportunity to learn the rules of the law, they're particularly unable to actually state what they should and shouldn't have done. And of course, these are all factors which must mitigate in the circumstances. There is a huge volume of research which, unfortunately, the knockout punch research hasn't been done yet in terms of rigor and numbers of individuals seen. A lot of our information has been accumulated over time on an individual or small group basis. But the individual cases in themselves can elucidate. And of course, when it comes to the courts, you're dealing with an individual, irrespective of what the sort of group research has shown. There's one particular individual who, completely faultless life, ends up committing an indecent act with a niece of his, and completely out of character with him. And it was only when he was noticed to be urinarily incontinent that someone thinks there might be some other explanation, as apart from as he was facing a trial for paedophilia. Of course, they found a frontal brain tumor, which they removed, and his behavior completely reverted back to normal. He was distraught and inconsolable by his behavior and racked with guilt. And then about 18 months later, the behavior started again, and they rescanned him, and the tumor was back. And when they removed the tumor, the behavior stopped, and he was remorseful all over again. So in terms of individual cases, you can see direct correlations with the frontal lobes and behavior. The difficulty is convincing the courts that that is the case in a particular in the particular case that you're dealing with. This is a excellent critical review, a bit old now, but it just shows you in relation to aggression that the evidence is not overwhelming, and points towards the impulsive rather than the predatory type. Anyone who's interested in the aggressive aspect, there's a ginormous book here by Adrian Rain, is just out on the anatomy of violence, the biological roots of crime, and his book is devoted specifically to the biological aspects of which he's persuaded. So I will leave it at that. Thank you.